Management of cardiopulmonary bypass. Cardiopulmonary bypass circuit is composed of pump, oxygenator, heat exchanger, reservoir, filter, sucker, and vent cardiopulmonary solution system. So we need to understand the physiology of circulation, preventing the blood from clotting, and pump blood to the pump and ventilating. So the Sigmamotor pump, this is a device as occlusive fingers that rhythmically compress the tubing to propel the blood in the forward direction. Roller pump and centrifugal pump. Centrifugal pump is a cone-shaped impeller encased in a cone-shaped housing using the principle of constraint vortex to generate the pressure and flow. Delphin pump impeller blades that rotate and generate the flow and pressure within the head. The oxygenator is composed of disc oxygenator, screen oxygenator, solid disc rotating screens, bubble oxygenator, membrane oxygenator, which could be of silicon, elastomers, microporous polypropylene. Filtration could be screen and have pores in the medium that are of particular size, or it is better design and lesser trauma screen type and filter become more popular. Depth of filter contains a medium through which the blood flows. This is large wet surface and blocks any particle, thus prevents them from being carried in the fluid and steam, and they are retained on the internal medium surface by the surfaces. So this is a graph showing the cannulation. This is for cannulation, and this is cannulation and flow. Prime estimation, these are the formulas from prime estimation. Blood flow volume estimation, and pulsatile bypass flow advantages. It has increased urine volume, less metabolic acidosis, decreased stress hormone, decreased peripheral resistance, increased oxygen consumption, improved myocardial perfusion, improved cerebral circulation, and smaller blood volume. So, determination of the body perfusion, externally controlled variables, patient response to CVP, imaging effect of CVP. Externally controlled variables are systemic blood flow, temperature of perfusate, arterial input, reservoir, systemic venous pressure, pulmonary venous pressure, hemoglobin, albumin concentration, glucose concentration, ionic composition, arterial O2 and levels. Differences between pediatric and adult exposed to biological extremes, deep hypothermia, hemodilution, low perfusion. Wide variation in the pump flow rate, variation in the glucose supplementation and cannula placement, presence of aortopulmonary collaterals, and patient age and risk. The smaller circulating volume in the infants, higher oxygen consumption, reactive pulmonary vascular bed, presence of intra and extracardiac shunt, and immature organ systems, and altered thermoregulation, poor microemboli. Patient response could be the change in systemic vascular resistance, increase in the tone, decreased oxygen consumption, mixed venous oxygen level, depression of the cell-mediated immune response, metabolic acidosis, catecholamine response, change in the water body composition, thermal balance, and hypothermic bypass. Factors of the fluid shifting during the cardiopulmonary bypass are temperature, flow rate, thermodilution, plasma colloid oncotic pressure, interstitial fluid pressure, capillary permeability, and fluid balance. General effect, the preoperative factor, whether the heart failure or not, hemodilution and diminished coagulation, colloid pressure, main cause of the fluid retention, hypothermia, less potent cause of tissue edema, oxygenator, interstitial fluid pressure, capillary permeability, osmotic active component, myocardial. Body water change in oxygenator, the denaturation of the protein and destabilization of the soluble fat may affect the colloidal property of the blood, and also damage of platelet and WBC may cause vasoactive substances, and microemboli may contribute to edema. Increase hematocrit due to plasma volume shifted into the interstitial space or excreted as urine. Plasma volume decrease in 24 hours after cardiopulmonary bypass. especially in second day, and regain ECF or total body water from 2 to 5 days post-operatively in usual patients. Interstitial fluid pressure is different due to the compliance of the tissue, non-compliant or subcutaneous tissue and muscle, less myocardium compliant. Damaging effect: exposure of the blood to abnormal event, exposure of non-endothelial surface, shear stresses, incorporation of abnormal substances, arterial blood. Systemic responses: injury to the blood elements, emboli, initial event, blood contact, platelet activation, coagulation, cascade, contact system, fibrinolysis, and vasoconstrictions. Injury to the blood elements: the contact and synthetic non-endothelial cell surfaces, turbulence, activation, osmotic forces, and shear stresses activate, but also injure the blood elements. The plasma protein and lipoprotein are progressively denatured during CBP. Protein denaturation increases the plasma viscosity, decreases the solubility of the plasma protein, produces macromolecules that aggregate, increase polarity and the number of the reactive side groups, and alter the electrophoretic pattern of the plasma protein. Denatured proteins are also probably removed from the plasma by the reticular embolization. The CBP system produces a variety of gaseous blood and derived from all foreign body. CBP circuits cannot prevent generation of emboli, but are designed to prevent and remove the macroemboli defined as emboli greater than 40 micromillimeters. The architecture of the vascular system dictates that the macroemboli can cause more ischemic organ damage than microemboli. Massive air embolism, macrogaseous emboli, and nitrogen embolus, fat platelet aggregates, spallation of the tubing, and exogenous emboli must be prevented and filtered. Inflammatory response: contact of the blood component with the artificial surface, ischemia, reperfusion injury, endotoxemia, and trauma. Whole body inflammation: the material dependent factor, hypo-oncotic pressure by priming, endotoxic translocation, cytokine release, retransfusion of the shed blood, and highly activated by the tissue contact. High concentration of the plasminogen activator. Material dependent factors: surface characteristic, activate complement system, blood pump, shear forces causing the hemolysis, lipid membrane coats, spoilation from the tubing causing circulation. Deleterious effects of interaction include protein denaturation, activation of the clotting factors, platelet aggregation, lipid peroxidation, activation of the complement cascade, postoperative pathophysiologic effect, impairment of the alveolar gas exchange, renal insufficiency, coagulopathy, cerebral dysfunction, and vague systemic toxicity action. This is a brief complement way. Inflammatory mediators: C3A and C5A are the potent inflammatory mediators known as anaphylatoxins. These anaphylatoxins are smooth muscle spasmogens and result in the changes during the vasoconstriction, increased vascular permeability, induction of the histamine release, and modulation of the host immune responses. Overall levels of C3A are directly dependent on the duration of the cardiopulmonary bypass, younger age, and at operation. C5A is unique in that it is rapidly bound to circulating neutrophils and that is sequestered in the pulmonary circulation. C5A stimulated cell-release superoxide lysosomal enzymes and proteases. A rise of this magnitude implies extensive degranulation or destruction of neutrophils circulating to the course of cardiopulmonary. Optimal conditions: the prevention of the ischemia, reperfusion injury, minimization of the cell swelling and edema, prevention of intracellular acidosis, and provision of substrate for regeneration of the high-energy phosphate on reperfusion. Vasomotor activity: minimal perfusion pressure, 35 to 45 millimeters of mean, and the bypass flow of normothermia 2.2 to 2.4. Relative vascular resistance to the blood flow: arterial system 93%, aorta 4, large artery 5%, main branches 10%, terminal branches 6%, arteriole 41%, capillary 27%. Venous system is 7%, venule 4%, terminal veins 0.3, main branch 0.7, large vein 0.5, and vena cava 1.5. Vasomotor activity. The initial drop in the peripheral circulatory vascular resistance at the beginning of the cardiopulmonary bypass commonly occurs in last 5 to 10 minutes. Dilution of catecholamines, homologous blood syndrome, incompatibility reaction of the blood, trauma state evokes the release of histamine, cold colloid priming effect, smooth muscle tone, gradual recovery of the progressive increase in peripheral resistance, gradual shift of fluid from vascular to cell and intercellular space, viscosity change in velocity gradient, and hypothermia itself. Venous compliance, effect of the cardiopulmonary bypass on venous tone. Low venous pressure, low temperature during the cardiopulmonary bypass cause vasoconstriction, but before cardiopulmonary bypass anesthesia, drug surgical manipulation also decrease the venous tone. Vasomotor state before and after surgery, the compensatory venous constriction is masked following the cardiac surgery and 70 to 80% reduction in the venous capacitance in early postoperative period. Vasodilators of the venous tone after cardiopulmonary bypass, nitroglycerin primarily on the venous capacitance, effective vasodilatation, return of the venous capacitance to normal. Nitroprusside and nitroglycerin equivalent effect on reducing the arterial resistance. Sometimes uh, nitroprusside reduces the coronary perfusion. Neural effects mainly determined by norepinephrine sympathetic innervation. Smooth muscles are plentiful and cutaneous splanchnic veins, while little in the skeletal veins, but not significant due to big muscle mass. Smooth muscle activity, tone, norepinephrine. So active vasoconstriction in cutaneous veins. Passive effects as a result of distensible and compliant nature of elastin and collagen fiber resistance in veins. Hypothermia aim protect the tissue from the ischemia secondary to inadequate perfusion and oxygenation during the cardiopulmonary bypass. Pitfalls: alteration in the microcirculation associated with reduced microcirculatory flow rates and tissue perfusion, more or less production of some cytokines than normothermia and cardiopulmonary bypass, more pronounced alterations in the platelet aggregation endothelial-related coagulation rather than normothermic cardiopulmonary bypass, steep relation between PT, APTT and temperature. Hypothermia, oxygen consumption phenomena during the hypothermia and arrest. No reflow phenomena, change in plasma volume, damaging effect in circulatory arrest, brain function, renal function, liver function, cardiac function, increased intracellular ionized calcium by hypothermia, aggravated injury, hematological effects of hypothermia. Hypothermic adverse effects activate kallikrein, which increases the circulating kinin vasoactive peptide that produces vasodilation and increased vascular permeability, produces platelet activation, temperature dependent on morphologic alteration in the membrane and function. Fibrinolytic activity is altered by hypothermia alone. Hematologic effect: the platelet membrane dysfunction, fibrinolysis, depression of the clotting factor. Disadvantages of hypothermia: attenuation of the coagulation system, attenuation of the glucose regulation, attenuation of the endocrine system, attenuation of the immune system, damaging effect associated with rapid perfusion, cooling of the kidney, liver, lung, myocardium, longer duration of the cardiopulmonary bypass. Systemic hypothermia, adverse effect: cardiac arrhythmia, myocardial ischemia, coagulopathy, decreased myocardial contractility, left shift of the oxyhemoglobin dissociation, impaired function of the immune system. Pre-bypass hypothermia, potential benefit: modest reduction about 2 to 5 degrees, inhibition of the neurotransmitter release, reduction of the calcium mediated cell injury and reduction of the free radical formation, attenuation of the inflammatory response, adverse consequences, bleeding, infection, cardiovascular events. Post-operative hypothermia, adverse effect: respiratory diaphragmatic function is impaired, coagulation, hypothermia, hemodynamics, increase in the incidence of the atrial fibrillation, splanchnic hyperperfusion, neurological problems, cerebral metabolism is reduced. It impairs sodium potassium adenosine triphosphate, impairs the Mitochondrial adenosine triphosphate ATP translocase, impaired cytoplasmic reticular calcium ATPase, impaired oxygen hemoglobin dissociation, thus hindering the cell volume control, energy metabolism, calcium sequestration, and oxygen delivery. Disadvantages of hypothermia: effects of membrane instability, effects on enzyme function, effect on tissue calcium accumulation, effect of cellular volume regulation. Endocrine response: increase in catecholamine secretion, increased vasopressin or ADH secretion, paradoxical rise in atrial natriuretic hormone, altered response of the cortisol secretion, hypoglycemia, lipid metabolism is dominant due to the abnormal glucose metabolism, increased free fat secretion. Mechanism of hyperglycemia: reduction of in GFR or increased tubular reabsorption, alteration in glucose transport mechanism, non-pulsatile flow on organ function, decrease hematocrit and albumin level as decrease ECF volume, input of glucose from the exogenous sources, and glycogenolysis and gluconeogenesis. Hormonal and metabolic factors provide the basis of development of hyperglycemia. Usually returns to normal within hyperglycemia returns to normal within 12 hours. Increased glycogenolysis secondary to epinephrine increases during cardiopulmonary bypass. Abnormal pancreatic insulin response due to hypothermia. Impaired glucose transport and utilization. Binding of indigenous insulin to artificial surface during the cardiac bypass. Pitfalls is osmotic diuresis, dehydration, glycosylation of protein, and increased cerebral. Effect on cerebral function. Normally, the cerebral blood flow is independent of cerebral perfusion pressure over the range of 50 to 150, with the primary determinant of flow being cerebral metabolic rate. Outside of this range, the auto-regulation of the cardiopulmonary blood flow is directly related to CPP. Variables such as of such methods are acid-base management, mean arterial blood flow, and the type of perfusion and their effect on the cerebral circulation remains controversial. The global increase in cerebral blood flow due to the elevation of PaCO2 and is associated with cerebral vasodilatation and the critical reduction in perfusion pressure and jeopardize of the areas of the brain dependent of the flow through the stenosed vessels. Cerebral hyperperfusion may potentially deliver more gaseous and particulate microemboli into the cerebral circulation. The cerebral blood flow is also affected by anesthetic agents. Hematological effects: platelet dysfunction, thrombocytopenia, foreign surface, blood gas interface, hypothermia, reduction of coagulation factors, fibrinogen and plasminogen, reduction of the damage of arteries. General renal effect: ischemia as a major factor in the renal dysfunction with prolonged bypass. Early recognition of the renal failure correlated with decreased renal perfusion. Vascular effects are due to dilution of the circulatory and catecholamines. Microemboli and hemolysis can cause the renal dysfunction, hemodilatation, protect renal damage due to increased renal plasma blood flow, hypothermia, decreased renal glomerular filtration due to the cortical vasoconstriction, osmolar and oncotic agent, neural effects of hemodilatation, and endocrine action, increased ADH due to a low LA pressure, hypotension, and non-pulsatile blood flow. Edema after cardiopulmonary bypass in neonates: the capillary permeability is naturally higher in younger people. The greater exposure to bypass prostatic surface area related to the neonate endothelial surface area, larger ratio of the prime volume to blood flow than the older, exposure to the greater extremes of the temperature as well as low flow of the circulatory arrest, thereby increasing the risk of ischemia reperfusion. Pulmonary effect: the lung fluid exchange, excessive pulmonary capillary fluid filtration due to the capillary damage induced by the complement release and activation of the coagulation cascade. Hemodilution reduces the complications of intravascular coagulopathy, coagulation and increased pulmonary lymph flow and decreased blood use. The pulmonary capillary hydrostatic pressure Effective left ventricular venting, interactive causes of alveolar collapse, pleural cavity opening and the pleural lower lung volume, and increase in the amount of alveolar collapse, decrease in the lung volume due to the chest wall pain, and increase in the interstitial fluid of the. So this is the ideal perfusion flow rate. Body weight under 5, 200 over 60 to 70 mL per kg minute. Difference between infants and adults: smaller circulating volume, high oxygen consumption rate, reactive pulmonary vascular bed, presence of intra and extra cardiac shunt, immature organ system, altered thermoregulation, and poor microemboli. Recommended pump flow rate, normothermic cardiopulmonary bypass. So it starts from patient weight minimum 150 to 200 and patient weight over 50. Flow rate is 50 to 75. Minimal pump flow rate is from 100 to 8. Optimal flow rate during cardiopulmonary bypass: the normal flow and value of the total body perfusion supplied by the left ventricle and extracorporeal pump or both. Normal value of flow is 3.2 liters per BSA per minute. Oxygen uptake VO2 100 to 130 BSA per minute. Hemoglobin value 15 gram percent. Hematocrit 45%. Normal systemic transportation 20 volume percent, 3.2 lbsa per minute. Organ blood flow rate during the profoundly hypothermia, non-pulsatile hemodiluted cardiopulmonary bypass. Safe saturation of the circulatory arrest. Cardiac venting affects the myocardial effect, decrease intraventricular pressure, pulmonary effect, decrease pulmonary venous pressure. Evaluate valve function. Complications: myocardial injury at apex, air embolism, bleeding, and arrhythmias. Regulating factors: hydrostatic pressure, anatomic factor, metabolic control, autoregulation. Well correlates with myocardial oxygen consumption, the myocardial tension development, external work, heart contractility. Endothelial dependent cyclic guanosine monophosphate CGMP mediated vasorelaxation response to acetylcholine can cause coronary vasomotor dysfunction. Endothelial independent CGMP mediated vasorelaxation response to sodium nitroprusside. Beta-adrenergic cyclic adenosine monophosphate mediated vasorelaxation. Factors influencing the blood pressure: alteration in the vascular response, anesthetic agent, operative trauma, perfusion flow rate, priming hemodilation factors, perfusate, colloidal osmotic pressure, temperature, and other factors. Vasodilatory hypotension. Etiology is endothelial injury, release of cytokine, other inflammatory mediators. Treatment is suppressor, catecholamines, arginine, vasopressin, petrisen. Presence of arginine vasopressor deficiency, predisposing factor: hyponatremia, atrial stretch, and anatomical dysfunction. Multiorgan failure. Laboratory indices of the cellular death in every tissue with intractable loss of the peripheral vascular response similar to sepsis. The situation in general is accompanied by the excessive whole day edema, so-called as capillary leak syndrome. Organ discomfort recovery achieved. Abdominal complications. Incidence about 1% of the frequent in the valve surgery. Gastrointestinal ulceration associated with bleeding, acute gastric dilatation, cholecystitis, acute appendicitis, and acute pancreatitis. GI bleeding. The ulcer history is 50% frequent in old age men. Valvular disease, acute pancreatitis, 0.3% of the cardiopulmonary bypass mortality is 30% not related to MLA is labeled hypercalcemia, embolization, and low perfusion. Intestinal ischemia and infarction very rare due to embolization, cardiac failure, spasmodic pooling of cardiopulmonary bypass and disease. Potassium kinetics, urinary loss not related to urine volume, not equilibrium to interstitial space. Hemodilution, more interstitial space, acid-base balance, glucose metabolism, catecholamine, intrinsic catecholamine, decrease the serum potassium levels, propranolol, inhibit decrease in serum. Assisted circulation, control of blood activation, surface modification, physical modification, chemical modification, surface modification by inclusion of bioactive component, biomembrane mimicry, cellular seeding and lining. Inhibition of the initial events leading to the blood activation, platelet anesthesia, contact phase inhibition, complement inhibition, monocyte inhibition. Endpoint inhibiting biological cascades, antifibrinolytic drugs, modulation of the neutrophilic medium. Coagulation function test, coagulation time, ACT, partial thromboplastin time, prothrombin time, and thromboplastin degradation time and time. Protein C system action, plasma factors, protein CNS, endothelial bound, thrombomodulin bind to circulating prothrombin from complex that catalyzes conversion of the protein C to activated protein C. Activated protein C together with its cofactor protein S inhibit the further thrombin generation by inactivating factor 5A, factor 8A. Activated protein C neutralizes plasminogen activator, inhibitor of PA1, PAI3 and enhanced fibrinolysis. Congenital deficiency of protein C, resistance of factor 6A, hypercoagulable state. Aprotinin is inhibitor of activated C. Nature of aprotinin. Aprotinin is a polybasic polypeptide naturally acting serine protease inhibitor derived from bovine lung. It decreases fibrinolytic action, decreases platelet activation, inhibits Clerican activation, inhibits neutrophil activation, reduces cellular immune reaction. Nefomostat mesylate is a synthetic, specific and reversible serine protease inhibitor and has a potent inhibitory activity on thrombin. Hydrolysis of NM occurs mainly in blood and liver followed by glucuronic acid conjugation. It completely inhibits either the formation of activity of 12-way Clerican 2 or the key enzymes to conduct the system. It is thought to interact directly with platelets to reduce aggregation. Desmopressin acetate is a synthetic vasopressin analog that lacks the vasoconstrictor abilities, and this reduces the bleeding time and surgical blood loss, inducing the release of circulating levels of the coagulation factors 8 and 1 Willebrand factor. It improves the hemostasis in patients with certain congenital or acquired disorder platelet function. Adrenomedulin is a potent vasodilator peptide initially isolated from the adrenal medulla, but in the vascular beds of the organs such as the heart, lung, and kidney, synthesized by and secreted by the endothelial cells and the smooth muscle cells of the pulmonary vasculature. Impaired ability to synthesize and secrete ADM in the pulmonary circulation contribute to development of pulmonary hypertension. Multiple biological effects involved in the cardiovascular hemostasis. Issues with heparin use. Dose of the heparin evaluation to assess anticoagulation, heparin titration during CBP, protamine dose for reversal, assessment of the adequate reversal, heparin resistance, heparin rebound, and complications in therapy. Heparin inhibits both factor 10A and thrombin. Intravenous boluses are given, and extravascular depot, hemodilution, and hypothermia all affect anticoagulation. And heparin is primarily released by reticuloendothelial system and activated by heparin exerts the anticoagulation effect by enhancing the action of antithrombin 3, the major naturally acting inhibitor of the coagulation. ACT is a gross test of coagulation, such as affected by all aspects of coagulation cascade. In addition to residual heparin, destruction of serine protease, fibrinogenemia, fibrinolysis, and the platelet abnormalities, both quantitative and qualitative, can increase the ACT. Additional properties modulate the inflammatory response by inhibiting activation of the polymorphonucleoleucoside as well as component of complement cascade. Production and release of several endothelial vasoactive mediators include the endothelium and nitric oxide. Protecting effect of stenting of the myocardial ischemia and reperfusion injury. Heparin activates lipoprotein lipase, which releases the free fatty acid from the triglyceride. Alternative heparin are low molecular weight heparin fragment. Heparin is a naturally acting anticoagulant found in leech. Reversibility inhibits the thrombin, which is very high affinity. Other thrombin inhibitors is boroarginine and chloromethyl. So coronary artery bypass grafting without cardiopulmonary bypass, the complications of cannulation or clamping including bleeding, dissection, embolization. Consumption of the coagulation factor and platelet damage lead to bleeding, leukocyte damage leads to fever, leukocyte and platelet mediated endothelial damage leads to edema, complement induces increased vascular permeability, leads to interstitial edema, bradycardia leads to vasoconstriction, and platelet and fibrin microemboli leads to dysfunction. The causes of neurological abnormalities including platelet microemboli, air embolism, atherosclerotic emboli, aortic cross-clamping, aortic cannulation, and proximal graft. Complications of CABG including death, MI, CVA, infection, and bleeding. Bleeding is a significant aspect of CABG. It happens in 30,000 operations, 46% receive blood, and 5% return for bleeding. Death is the most worst complication, leukocyte-related target organ injury, transfusion. Intraoperative RBC transfusion causes has independently associated with LOF. The adverse outcome of blood transfusion after cardiac surgery, prolonged need for mechanical ventilation, impaired wound healing, multiple organ system, prolonged length of stay in hospital, increased post-operativity. So the transfusion of the CABG is associated with reduced long-term survival. The predictors of the postoperative bleeding is advancing age, small size of the preoperative anemia, antiplatelet, antithrombotic drugs, prolonged operation, high correlation or type, emergency operation, other comorbidities like CHF, COPD, hypertension, PVD, ECT. The studies reviewed the effect of aspirin on postoperative bleeding. So evidence is less convincing in different studies. The estimated amount of bleeding after the operation due to aspirin is 200 to 400 of increase in the chest tube loss, 0.5 to 1 liter of blood transfusion due to aspirin. Lower dose of aspirin protects such as well and associated less bleeding. So blood conservation intervention: identify the risk preoperatively. High dose of protein dose, lysine analog, cell saver, blood transfusion algorithms, modality approach. Blood conversion class 2 recommendation: preoperative epigen, intraoperative patient with thrombocytopenia, autologous pre-donation, off-pump bypass, alternative to blood sampling, total quantity management, discontinued Plavix, transfusion for hemoglobin less than 6 high trigger in elderly severe cardiac dysfunction ischemia, blood component transfusional bleeding. Association between aprotinin and serious end organ damage indicates that the continued use is non-prudent, and in contrast, the less expensive generic medications EACA and thromboxane A are safe. Blood conservation. So preoperative intervention including epogen, hemoglobin 16 ideally, a limit antithrombotic and antiplatelet drug effect, blood loss during operation, high dose of aprotinin, antifibrinolytics, meticulous hemostasis, speed of operation, perfusion strategies, mini pump, salvage sequence of blood, cell saver, pump salvage, and normovolemic hemodilution and pre-donation. Manage blood resources, process of care variables, multimodality approach including the post-op epogen, iron, and transfusion algorithms, and point of preoperative measures include consult bloodless medicine team for all patients and outpatient seen by bloodless medicine if available erythropoietin administration. Avoid delay in labs in patient awaiting surgery, serum ferritin levels in all patients. Bloodless medicine will decide the need for ferrilicet and angioseal recommended for all patients who may need surgery in next 48 hours, and vitamin K 10 mg oral for selected patients. A risk factor for transfusion: normalize INR preoperatively to convert the low Venox as needed. Aspirin, low risk patient, Jehovah's Witness, Plavix, discontinue 5 to 7 days. Garlic, vitamin A, E, SOV, and no alcohol for last 1 week. Preoperative anemia, major risk factor fusion. Intraoperative major aprotinin, autodonation, and 1 sponge technique. Blood return to the patient after cardiopulmonary bypass, and fibrillatory arrest for redo AVR patient, inpatient IMA. Miniature cardiopulmonary bypass circuit, self-save only, leg elevation, chair position, improve the venous drainage, antegrade retrograde priming, smaller venous line, 3 to 8 as opposed to 1 to 2, less prime, follow through, retrieve all blood from bypass circuits, full rebound into 36 degree before bypass. Optimize the cardiopulmonary bypass technology, reduce systemic inflammatory response syndrome, preserve platelet function. Aprotinin enhances the effect, decreases blood loss, avoid reduced graft patency of pump bypass, and applicable to ocean. Low prime circuit benefits: reducing the priming volume, reduce hemodilution, decrease blood component usage, and reduce foreign surface area, less contact activation. Summary: demonstrated safely and effectively, proven results, confirmed cost avoidance, low impact to surgical technique, procedure dependent, can be utilized on all procedures requiring cardiopulmonary bypass. Intraoperative measures: thrombin, bioglue, and point of care. Post-op measures: bleeding patient, coagulation profile, correct temperature, replace volume, positive airway pressure, cryoprecipitate elevation. Conclusion: a multimodality approach to blood conservation is essential. Guidelines are used to help guide the therapy and reduce the variability in practice. Aprotinin is an important adjunct to comprehensive cardiac surgery blood conservation program in the high-risk patient, Jehovah's Witness, and other transfusion-free cardiac surgery patient. Avoidance of the blood transfusion cardiac surgery patient decreases the cost, morbidity, and is likely to decrease the mortality. Thank you.